Hello, everybody. Thank you so much for joining us today. I'm Dr. Masha Livhits. This is Dr. Michael Ye.
Hi.
And we're endocrine surgeons here at UCLA. And today we'll be discussing what to expect after parathyroid surgery. So first, we'll just quickly review what the strength of the evidence is behind our recommendations for you today. Then I'll just give a brief overview of hyperparathyroidism and a reminder of parathyroid surgery. And then we'll talk about both the short and long-term expectations of what we should expect to happen after parathyroidectomy. Please ask any questions that you have on Twitter and on Facebook. So the first topic is really how good is the evidence to support our recommendations? So this was a sort of set of guidelines that the American College of Physicians put out as a grading system so that we can give you some measure of how good is the data that supports our recommendations. So for example, we may have a study where we randomize different treatments with thousands of patients. That would be very good quality of evidence. On the other hand, I may present to you data from my last 10 patients that I operated on. That would be relatively weak quality of evidence.
Yeah, this is one of the hardest parts of being a patient today or a physician today, which is the acknowledgement that science doesn't know everything perfectly. We have uncertainty, and some types of evidence are just stronger than others. And Dr. Livhits mentioned the randomized controlled trial. That's where we take 100 patients and we flip a coin and we assign half of them to one treatment and half of them to the other. And that is the strongest type of evidence, but that's a difficult study to do. So a lot of the medical science we have is actually of lesser quality strength than that. But we do want to familiarize you with the fact that we need to be skeptical when we look at evidence. You know, a lot of people do research on the internet. There's a difference between doing research on the internet and just looking things up on the internet. Doing research means you're actually scrutinizing how good is this evidence and being skeptical about it.
And we'll be very honest with you about the quality of the data that we have as we go through our webinar today. So as a reminder of what the parathyroid glands do. The parathyroid glands are small glands that are located here in the neck. They're usually just as large as a grain of rice. This would be a large parathyroid adenoma that's about 2 centimeters in size. And the job of the parathyroid gland is to produce parathyroid hormone. And that controls the calcium level in your bloodstream. So if the parathyroid hormone level is too high, that will usually leach calcium out of the bones predominantly into your bloodstream and cause the blood calcium to be elevated. So hyperparathyroidism is when one or more of the parathyroid glands are overactive. Then the surgery that we do removes the abnormal parathyroid gland. Usually there's only one gland that's involved, but in about 15 to 20% of cases, there may be more than one gland that's involved in this process. In terms of the surgery that we do, it's a fairly small, sort of low-maintenance surgery where the incision for us is just a little over an inch in size. We tend to look at all 4 parathyroid glands to make sure that we've seen all the ones that are abnormal. There are other surgeons that will remove the one that's abnormal seen on the imaging. Both techniques, I think have very good outcomes for high-volume surgeons. And then the important thing is to check the parathyroid hormone level after the surgery is done. So you can see this is the preoperative hormone level, about 200. And once we remove the abnormal gland, that hormone level should drop very quickly. So that about 10 minutes after excision, that hormone level should drop by at least 50%. And that's how we can confirm that we've cured that patient before they wake up. And the success rate for experienced surgeons should be greater than 95%, meaning that patient should not have a recurrence of their parathyroid disorder over time. So first, let's talk about calcium issues after surgery, both in the short term and then in the long term. So the symptoms of low calcium are very important to mention after surgery. This is one of the kind of main things that patients may complain about or may prompt emergency room visits after surgery. So symptoms of low calcium are really numbness and tingling around the mouth, in the fingertips. It can also be some cramping in the legs, maybe some overall feeling of weakness. They tend to peak 2 to 4 days after the surgery. So the calcium level drops, in the first couple of days. So at 2 to 4 days is really when the calcium tends to reach its sort of lowest point, and that's when patients have most of their symptoms. And if it's severe, which is quite rare, but if it's severe, it can progress to things like tetany, which is where all the muscles seize up and you can even stop breathing, or have seizures. So that's obviously an emergency, and what we really want to do is to prevent those severe symptoms from developing. developing. So this is sort of a fun test to look at. This is something called the Schwastek sign. You can tap the nerve here, the facial nerve, in front of the ear, and then it will cause the muscles of the lip and some of the facial muscles to twitch, and that would be a sign of low calcium. But it's really that numbness and tingling in the fingertips. Those are the kind of most specific signs to look out for low calcium after surgery. So the symptoms are really related to either the calcium is actually a bit low or it may be normal. But if your body is used to having a very high level of calcium, then that relatively normal calcium level for your body can give you some of those same symptoms. So for our patients, we routinely discharge them on oral calcium and vitamin D supplementation because we want to prevent those symptoms from developing. And the dose of calcium that we give, it really depends on how high your calcium was before surgery. So if your calcium was very high before surgery, then you're going to have a larger relative drop and you'll probably need a little bit more calcium supplementation. And it's fine to take extra doses in that first couple of week period if you have more symptoms. And really the key part is communication, primarily with your surgeon. We have a large distance program, so our patients may come from all over the country. They often travel back home after a couple of days, and we are available to help. And we can treat almost all of these issues as an outpatient with just good communication. So we can tell patients to take extra calcium, and as long as there's good communication with the surgeon, primarily, then patients can stay out of trouble after surgery.
Yeah, some of the stuff sounds pretty scary, but the truth is most people do really well. A thing I'd like to add is that, for a lot of people, prior to surgery, the calcium is really high. And this may sound strange, but a lot of our bodies will become addicted or accustomed to an abnormal calcium level. And when the calcium then falls to normal, it feels funny. It feels like that numbness and tingling you were mentioning. And in almost all instances, it's not dangerous. People just need to take a few calcium tablets and it seems to get better. We do a lot of parathyroid surgery on Thursdays. So classically, we get a call on Saturday morning if somebody's having some symptoms. And it resolves over time. Over a 4 to 6 week period, almost everybody grows accustomed to the new, healthier calcium level, and they sort of go on very well from there.
Yep, absolutely. So usually after a few weeks, things are pretty normal. And then most of those patients can wean off calcium at that point. So I think a very common question is, should I continue to take calcium supplementation long term? And so these are the recommendations and it's really to kind of help your bones rebuild long term if you already have developed some degree of bone loss. So the recommended calcium intake, for example, for a woman over age 50 would be 1,200 milligrams of calcium per day. And for a man, it would be 1,000 milligrams of calcium per day. Ideally, you would get most of this from your diet. It's how it's best absorbed. So you can look at your kind of daily diet and see how much calcium you think you're getting, either from dairy intake or it can be from salmon. There's a variety of foods that have calcium in them. And if you feel that in your diet you're not getting close to these numbers, that's when supplementation is helpful, about 500 milligrams at a time. And we recommend not taking more than 1,000 milligrams of calcium per day. There's been some data that there's increased risk of heart disease if you over-supplement calcium long term, but you do want to meet these daily recommendations with a combination of diet and supplementation if necessary after the surgery to help keep your bones strong.
Yeah, I agree. And after surgery, we commonly will have our patients on a higher dose of calcium for just a few weeks. But if you're going to take something every day, don't go overboard.
Yep.
This would be the maximum you want to take.
Absolutely. And then in terms of vitamin D supplementation, you want your vitamin D level to be in the normal range. That's typically above about 30 to try to prevent worsening bone loss if you already have some degree of osteopenia or osteoporosis. So that's a perfect segue to discuss a little bit more the long-term improvements we might expect after parathyroid surgery.
Great. So my job in the next few minutes is to talk about some of the physiologic or physical health improvements after parathyroid surgery. And then Dr. Livhits will get into some of the quality of life issues later on. I imagine some of you might be more interested in her topic. All right, so a lot of my topic is going to be about bones and stones. You probably heard that little rhyme. That's a lot of the reason the complaints focusing on hyperparathyroidism are often about bones and stones, and so sometimes the way people get better are often in those two domains. Some of you may know about osteoporosis, which is the loss of bone mass over time. Commonly we see it in postmenopausal women. You see the bone density decreasing here in osteoporosis, and we worry about fractures, particularly in postmenopausal women. It's important to know that age and sex affect bone mass. So here you see that males in blue generally have higher bone mass, and it comes down with age, but not so dramatically. In women, there's a peak bone mass that's achieved around the age of 30, and that comes down, and particularly with the loss of estrogen at the menopause, we see a change in the slope of bone mineral density. It's also important to remember that a lot of our patients with hyperparathyroidism are women in this 50 to 60 range. And so that's why we're so concerned about their bone health. Those women with hyperparathyroidism potentially have two things wrong, right? They lost estrogen and then they have a parathyroid problem on top of that. It's important to know that most osteoporosis is not caused by hyperparathyroidism. A lot of people just have garden variety osteoporosis. Maybe multiple people in their family have osteoporosis. Some people with a more slender or slim build would be more have a higher tendency toward osteoporosis, and certain ethnic groups have different bone mineral densities. And we're just talking about today, we're talking about the subset of people with osteoporosis that have hyperparathyroidism. All right, so to summarize, osteoporosis is common, especially in older women. Hyperparathyroidism is also common in the same age group. So the important message is that primary hyperparathyroidism is a reversible cause of osteoporosis, and that's why we chase after it pretty hard. Some of these other things, like what's your genealogy or what's your build, maybe we can't change a whole lot. But if you have an operation for hyperparathyroidism, that's something, an intervention that can bring you back to better bone health. Parathyroid surgery is curative, safe, and simple in expert hands. All right, so some science here. We're going to look at bone mineral density over time in women with hyperparathyroidism, and we're going to look specifically at the femoral neck, which is a fancy word for the narrow part of the hip. And the reason we're interested in this is we are scared of hip fractures. We don't want our patients to have hip fractures. All right, so if you look at women who are untreated, all these women have hyperparathyroidism, and you look at untreated women in the black bar here, over time their bone mineral density is going down pretty far. Not only are they aging, but every day this parathyroid problem is taking more and more calcium into their bones and putting it into the urine, and then it goes down into the toilet, sadly. Now, the next group, let's look at the white bar, parathyroid surgery. So those people, their bone mineral density goes up for a while, and then it starts to come down a little bit. And that, at first blush, may be a little disappointing that it eventually comes down. But remember, none of us can live forever. We are all aging. And so what you need to focus on is the fact that the people who have parathyroid surgery are doing much better than the black bar. Okay, the white bar people are doing much, much better than the black bar. And even over time, the white bar stays better than the black bar. And our understanding is that during that time, that difference, we're preventing fractures. People are avoiding fractures during that time. Now, you may be wondering, what about the diagonal striped bar? Well, those are people who get medicines, also known as bisphosphonates, to treat osteoporosis. And here, if you just look superficially, you would conclude that the effect of medicine on bone mineral density is similar to the effect of parathyroid surgery. But I want to tell you that that's very deceptive, because even though bisphosphonate medications may improve the strength of bone, as you can see on a scan, those people somehow still manage to have a high fracture rate for reasons that we don't completely understand, okay? And so, it's great to talk about bone mineral density. There's another scientific slide for you. But the real endpoint, what we really care about as doctors and what our patients really care about is, am I going to fracture or not? I think that's much more important than the bone mineral density measured on a scan. And here are the fracture data. So if you look at hip fractures, in people who have hyperparathyroidism and have no treatment, this is the number of hip fractures they will have among a group of 1,000 people over 10 years. There will be 56, almost 56 fractures. Among the people who are treated with parathyroid surgery, the hip fracture rate is much, much lower, okay, from 56 down to 20. Now, in medicine, that is a massive effect. And if we think about how many people have hyperparathyroidism in the country, how many hip fractures we could save in the country, that becomes a really important number. And in a moment, I'll tell you a bit more about what's so bad about hip fractures. We also looked at other types of major fracture. It could be an arm fracture, it could be a pelvic fracture, it could be a lower leg fracture. And same thing, 206 fractures over 10 years in a group of 1,000 people if they are not treated. Again, parathyroid surgery is going to prevent a lot of fractures. And bisphosphonates, the medication, okay, even though it improved bone mineral density as measured on an X-ray, it did not reduce the rate of fractures. And you may see here that the rate of fractures in the medically treated group is actually higher than if you did nothing at all. Okay, the reasons behind that are complex because those patients may be a little sicker. They may be older and more frail. So I don't think we can really conclude that bisphosphonates make fractures more likely, but I think we can safely say that the medication certainly doesn't reduce fractures. And if you have hyperparathyroidism and you want to stay safe and avoid fractures, there's a very clear choice here. This is strong evidence that you should have parathyroid surgery. I'm going to pause if you want to weigh in.
I would completely agree with that. I don't have too much more to add other than that there's not really data that in the presence of hyperparathyroidism that has not been treated, that bisphosphonates are effective.
Yeah, so a few bullet points here. If you have osteoporosis, check the calcium level because if you have hyperparathyroidism, you could have a reversible cause of osteoporosis. If you have high calcium, it's probably hyperparathyroidism. We know that 9 times out of 10, if you've got high calcium that's high over and over again, this is going to be the cause. Parathyroid surgery reverses hyperparathyroidism-related bone loss and reduces fracture risk. And every Thursday, we might do 10 parathyroid operations, and when I go home, I feel happy because I know if we did 10 parathyroid operations that day, we likely prevented 1 major fracture, and so we sleep well at night. Bisphosphonate medications such as alendronate, also known as Fosamax, ibandronate, also known as Boniva, do not reduce fracture risk in primary hyperparathyroidism. And I want to point out that a lot of this work we've done is only done over the past 2 years or so. There are a lot of physicians who may not know this, so it's important that you know this, and we continue to try to push this work out to our communities and our physician groups. How bad is a hip fracture? It's really bad, all right? So if you have for instance, when I think about growing old, this is something I'm afraid of. I hope I don't ever have a hip fracture. A lot of people who fracture a hip, 20% of them will not survive more than 2 years. It's not that the hip fracture itself is lethal, but the complications that happen afterward, a blood clot, a pneumonia, an infection of some kind, those tend to be very dangerous for older people. Furthermore, if you have a hip fracture, on average, that's 1 year of rehabilitation, and 60% of these people will never walk unassisted again. We really don't want this to happen to anyone, and that's why we take this so seriously. This is a visual way of representing our findings, okay? So parathyroid surgery reduces the risk of hip fracture, reduces the risk of any fracture, and again, there's no benefit to medical treatment. This is another cool study we did. I hope you like these pretty pictures. This is what we call a visual abstract or a visual way of representing our scientific findings. And here, we point out that here the people who have a lot of fractures, okay, observe people who don't get surgery have a lot of fractures. People who have successful parathyroid surgery is reduced more than half. However, remember, not every parathyroid operation is successful. Somewhere between 5 and 15% of parathyroid operations don't work. This is more of a problem for patients of surgeons who don't do parathyroid surgery very often. And as you can see, the fracture rate if you have a failed parathyroid operation is just the same as if you had never had surgery at all. And in this study, the way we defined a failed parathyroid operation is if after surgery, the calcium still was high. And that often means that the surgeon didn't find all the bad parathyroids. Do you want to comment on that?
I think that the great part of the study is that these are very similar groups of patients. All of these patients were felt to be good candidates for parathyroid surgery. So they're two very similar groups of patients. I think this is pretty good quality evidence that a successful operation helps to prevent fractures.
Exactly. So Dr. Livhits' point is that the people who had successful parathyroid surgery and those who had failed parathyroid surgery are essentially identical walking into surgery. They're the same age, they have the same sex, they have the same risk factors, they have the same bone mineral density. And when we talked about the quality of evidence, this is very similar to a randomized trial, right? Some people kind of randomly had failed surgery, and some people randomly had successful surgery. I mean, maybe not randomly, but you know what I mean. We certainly didn't say you're going to have a failed parathyroid operation. So what it means is that this proves that parathyroid surgery really works in preventing fractures of the hip and other major bones. I think I'm just going to end with this slide. I said I'd talk about bones and stones. This is my one stone slide. So today we had somebody come in with a history of stones. As a man, men more commonly have stones. And what I tell people with stones is that the day before you had surgery, you are 500 times more likely to have a stone than I am or a regular person has. After surgery, the risk of making a new stone decreases, but it takes a little while, somewhere between 5 and 10 years before you resemble just a regular person without hyperparathyroidism. So this problem doesn't really solve itself overnight. Did you want to add anything about stones?
No, I mean, do you think that it's probably that there are some small stones that have already developed that just take some time to clear?
Yeah, it's a great question. Yeah, like so there are people who have lots of stones sort of stuck in their system somewhere, and those aren't going to magically disappear. So it's possible those continue to trickle out.
Yeah.
Having your hyperparathyroidism cured surgically reduces the likelihood that you're going to make more stones.
Significantly.
Yeah, so this whole idea that the calcium is being taken out of your bones and put into your blood, and of course the kidney's got to filter all that, and then all that calcium excessively goes into the urine, it stands to reason that those people are going to make more stones. So we just want to reverse that process. The reason I put that up there is, again, what people should expect. There are people who have parathyroid surgery who have stones, and then a couple months later they still have another stone, and they feel upset about that. But those people shouldn't feel discouraged. Already their risk of stones has come down a lot. It's going to keep coming down, and those people will eventually essentially come to a normal state. Yeah, I think the next one is yours.
Great. So as physicians, we really tend to focus on objective things like osteoporosis, kidney stones, kidney function. Those are things that are physically dangerous, could be life-threatening, also things that we can measure well. As patients, I think one of the main things that patients with hyperparathyroidism really worry about is their quality of life. To what degree is hyperparathyroidism impacting their life, and to what degree may it improve after surgery? Several decades ago, when patients would be diagnosed with hyperparathyroidism, it would be because they had severe fractures, kidney stones, uncontrollable high calcium. Whereas now, most of our patients are diagnosed because they were, quote, asymptomatic and just had a routine laboratory testing that showed high calcium. So those patients may be considered as being asymptomatic or not having any symptoms from their hyperparathyroidism. But is that really true? So when you talk to most patients with hyperparathyroidism, they will have some degree of, these are the most common types of symptoms: fatigue, muscle pain or joint pain, nausea and constipation, frequent urination. Brain fog is a term that's used very commonly, particularly with short-term memory problems, depression, anxiety, and trouble sleeping. The problem is that the cause of these types of symptoms is often unclear. These are relatively vague symptoms that certainly could be due to hyperparathyroidism, but there are an overlapping number of conditions that may contribute to some of these symptoms. So it's hard to know in any individual patient whether it's hyperparathyroidism causing all these symptoms or whether it may be something else contributing. But we do know that there are several studies that show improvement in these types of symptoms after surgery. So I'm going to discuss a few of them. So are patients truly asymptomatic? This was a cool study looking at 150 patients who had parathyroidectomy, and they were compared with patients who had thyroid surgery. Now, these patients had normal thyroid hormone levels, and they had a thyroid nodule that was removed, so they don't really have any reasons to have any particular symptoms. They're sort of a baseline comparison group. And so patients who had a parathyroid disorder prior to surgery, 95% of them had symptoms including fatigue, exhaustion, weakness, thirst, pain, constipation, these types of symptoms. And so the black bars are patients who had parathyroid surgery. The striped bars are patients who had thyroid surgery. These are your controls that resemble the normal population. And this is before surgery. So you can see all the black bars tend to be higher. So patients with hyperparathyroidism have more of these symptoms before surgery. And 95% had some improvement after surgery. So the change, the black bar, as it goes down, that means more of an improvement. So you can see that the patients who had parathyroid surgery, they tended to have significant improvements, particularly with fatigue, with feeling weak, feeling thirsty, depressive symptoms. Whereas the patients who had thyroid surgery, none of those changed, because that thyroid surgery we wouldn't expect would really change any of these types of symptoms. Here's another study. This is a study of 50 patients who were randomly selected to either undergo parathyroid surgery or observation. So a fairly high quality study, but only 50 patients. And you have to think about which patients agreed to be randomized. So there are certainly patients who, with hyperparathyroidism, would not agree to be randomized because they, have an opinion about what they would like to have done. It's a major decision. But 50 patients did agree to be included in the study, and you can see that this is at 6 and 12 months after surgery. And at 6 months, there were some improvements with respect to bodily pain, mental health symptoms, with vitality, and these improvements tended to become even greater at 12 months after surgery. So a lot of people will ask, how soon will I get better after surgery?
It's a very common question.
Yeah.
I just want to note that when we use the term randomized, it means that we toss if you agree to be part of the study, we literally toss a coin, and you can be assigned to either surgery or no surgery. But yeah, please go on. I just wanted to clarify that term.
Yeah. So, there are a lot of patients that I find have some improvements even a few weeks after surgery. There are more patients that have improvements a few months after the surgery, and even up to a year there could be continued benefits in these types of symptoms. The other thing I want to point out is that some of these improvements were somewhat modest. So we can show you a graph like this, and there's a difference that may be statistically significant. When we do our mathematics, we do see a significant benefit, but clinically, what does that actually translate to? Will there be a dramatic improvement in your symptoms? So this improvement was somewhat more modest. This is another study that looked at the long-term effects of parathyroid surgery. So these were 78 patients, again, who had parathyroid surgery, and they were compared to patients who had a thyroid surgery. So these act as sort of your control patients. And they assessed something called the PASS score. This is a parathyroidectomy assessment of symptom score. It's a quality of life score that is specific for patients with hyperparathyroidism. It includes the things in that blue box over there, which are very common complaints. Bone pain, joint pain, feeling tired, mood swings, depression, being forgetful and thirsty. So this was a group that looked at the most common symptoms of patients with hyperparathyroidism in these kind of neurocognitive domains, and this is what they came up with. And you can see that before surgery, the parathyroid group, the levels were about twofold higher compared to the thyroid group. So patients with hyperparathyroidism have many more of these types of symptoms compared to their controls who are same age and same sex. However, after surgery, you can see that at 1 year, the levels came to be about the same. And at 10 years, that stayed also about the same. So even about a year after surgery, it seems like most patients who have a successful parathyroid surgery, their symptoms come to resemble a normal type of population. And that's really important for us to know, will it persist long term? So at least in this study, looking at 10 years out, that seemed to be the case. So again, just kind of mentioning the quality of the data, there are 3 studies where patients were randomly selected to have surgery versus observation, and there was some benefit in these types of neuropsychiatric symptoms seen in the studies. But we have to remember, again, that not all patients will agree to be included in the study. So, it may be a selected group of patients, and that there are a lot of patients who will drop out. A lot of patients, as we follow 10 years out, who won't complete that follow-up survey. And those may be the patients who are not doing well. And so it's more difficult for us to re-engage with them. So we just have to always take that with a grain of salt. So in summary, most studies do show some benefits in these types of domains after the surgery. But when you compare the studies, there are benefits seen in different scales, meaning in some studies, we see mostly an improvement in fatigue, and other studies, it may be mostly an improvement in mood or sleep. So for an individual patient, it's hard for us to know in what domains you will get better, and whether it will be a small or a large difference. But we know that as a group, most patients will have some improvements in some of these symptoms. And so there are certain guidelines from the National Institute of Health that talk about which patients are really good candidates for surgery. Those are not black and white guidelines, but they are helpful, just for us to consider. And they include things like osteoporosis, the degree of higher calcium is. Traditionally, these types of symptoms, the fatigue and these kinds of cognitive symptoms, they're not included in the guidelines. But the American Association of Endocrine Surgeons last year, looking at all the data and realizing how much this affects patients' quality of life, did include it in our guidelines from last year as a potential thing to consider when you're considering whether a patient would be a good candidate for surgery, to think about these types of symptoms. anything you'd like to add?
I totally agree. But, the hard part is when we talk about bones and stones, I mean, if somebody fractures something, it's easy to measure. By the same token, if you have a stone, we can catch it in a filter and we can measure it. Some of these quality of life issues are much more confusing, much harder to measure. And I think if we're going to be honest, a lot of the data that we've shown you on quality of life, you saw the symptoms of that blue box, right? Fatigue, feeling weak, bone pain. The evidence for that is low to moderate.
Yes.
Low to moderate. And I think we should come clean with one of our motives in bringing you this session is we want people to have the right expectations. I'm worried, one of the challenges of practicing medicine in the internet age is people go on websites that may be trying to oversell some of these benefits of parathyroid surgery. And the bones and stones benefits, they're real. Yeah. Some of these quality of life things are a little harder to achieve. And I just want to caution the audience today that parathyroid surgery is not a miracle cure for everything that ails you. It's really not. And if it sounds too good to be true on the internet, it probably is too good to be true. So we want people to have realistic expectations for what their life is going to be like after parathyroid surgery. So please go on.
Absolutely. So I think that pretty much concludes our presentation, and we'd be very happy to answer any questions that you may have about anything that we presented or anything related to what you may expect after parathyroid surgery. Please ask any questions on Twitter or on Facebook. Okay, let's see. Long term, when should I be concerned about blood levels of parathyroid hormone level or calcium? What is too high?
Yeah, great question. So after surgery, we often ask our patients to have their blood calcium levels checked 3 and 6 months after surgery. And we definitely want the calcium to stay comfortably in the normal range, which is between 8.5 and 10.5. I like a good solid 9 to 9.3 if you ask me. If the calcium is high, 10.5 or greater after surgery, then you probably need to be reevaluated.
Yes, and for patients who have high calcium before surgery, a cure is defined as having normal calcium long term. So 6 months after surgery, your calcium should be normal. It should continue to be normal. The parathyroid hormone level sometimes changes a little bit up and down, depending on your vitamin D level, your kidney function. So the most important thing is to have a normal calcium after surgery, and preferably we would like the parathyroid hormone level to be normal as well, but it's okay if it goes up and down a little bit as long as the calcium really stays normal.
Yeah, I definitely want to echo that. The key number after surgery is the calcium level. So long as that stays normal, you're probably going to be fine. You're probably going to realize all those benefits in terms of bone, stones, and quality of life. There are some people, we do sometimes get this question, it's been a year, 2 years, 3 years after parathyroid surgery, and my calcium's normal, but my PTH, the parathyroid hormone level, might be a little high. Usually that's nothing to worry about. As Dr. Livhits said, in those cases, we want to make sure the vitamin D level is normal. We want to make sure that the kidney function is normal, because if either one of those things are off, the parathyroids will respond normally by raising their PTH secretion. Usually a high PTH level, not too much to worry about. We see that in a small fraction of our patients after successful parathyroid surgery.
Next question is, how much pain can I expect after the procedure? So typically, this procedure doesn't have too much pain, okay? And the first couple of days after surgery, there can be some soreness inside the throat. Most people will complain of a sore throat on the inside for a couple of days. We do use a lot of local numbing medication so that, patients may have numbness going up to their ears, and we like to see that. It means our local numbing medication is working. But the main thing is just a couple of days of soreness, maybe a day or two of taking pain medication. And after a few days, most patients are feeling pretty good.
Yeah, I don't think it's that painful. I personally have never had the operation, so I don't know if it's painful or not. But most of our patients, when I see everybody, as soon as we finish, I ask them on a scale of 1 to 10, how bad is the pain? And the usual answer I get is a 2. And I don't even like our patients to have a 2 pain, so usually that's when I give them another dose of pain medicine to make sure they're happy and smiling. Not much pain involved, but it's still kind of scary, it's still kind of an operation.
Yep. Okay, another question is, are these disorders genetic? Is there a hereditary component?
There is, but most of the time, and I would say 95% plus of cases, most of the cases we see are sporadic cases. They're not caused by a gene mutation that you could, for instance, pass on to your children. A small number of patients have familial hyperparathyroidism, which takes several forms. There's several familial syndromes that have hyperparathyroidism. Probably the most well-known one is called MEN, or multiple endocrine neoplasia type 1. So we do have some families here in Southern California in which everybody has hyperparathyroidism and we take care of them, but that's rare. Most cases of hyperparathyroidism are sporadic. You want to add anything?
No, just, particularly if you're a patient who presents in their 40s or 50s without a significant family history, the risk of a hereditary condition is exceedingly low. Okay, another one is, how do you maintain healthy, well, this is about the thyroid, but we can maybe discuss that as well. How do you maintain a healthy thyroid? Any tips to maintaining healthy thyroid hormone levels?
Oh, first I just want to differentiate. The thyroid and parathyroid are different organs. They're just kind of neighbors to each other. They both secrete hormones, which is something they have in common. But the question regarding good thyroid health, most people don't really need to do anything. It works pretty well on its own. In women, particularly around the age of 45, you may want to occasionally have a thyroid function checked. Other than that, we don't do a whole lot.
Yeah. I think as an aside, the things that you can do to try to prevent osteoporosis, to try to keep your bones strong, the first one would be some weight-bearing exercise. And it doesn't have to be, weightlifting, but anything you're doing where you're up on your feet and your bones have some resistance, that's probably the most important thing that you can do to try to prevent osteoporosis and keep your bones strong. Have adequate calcium and vitamin D intake. Try not to smoke or drink excessive alcohol, and look at the medications that you may be taking. In particular, steroids, for example, may contribute to osteoporosis. There's nothing else in particular, I think that a patient can really do to maintain.
Yeah. So in medicine, a lot of times when we want to produce a benefit for a patient, sometimes we take on a little risk as well. What we like to say to our patients is one thing you can do that has almost no risk but a lot of benefit is exercise. Exercise and eat right and don't smoke. And after parathyroid surgery, we do want our patients to bear weight. And the classic story about this is if you look at measure the bone density in a baseball pitcher's arm, it's double in the pitching arm than the non-pitching arm. And think of the forces that baseball pitcher is putting his or her arm through. So if you stress your bones, they will strengthen. And so that's something you can do for your health after parathyroid surgery.
Absolutely. And I think the last question is, are thyroid disorders connected to facial paralysis like Bell's palsy? I would say no.
I don't think so. The question was about Bell's palsy and other movement problems of the face. They're pretty separate disorders.
Yeah. Do we have any other questions? Okay. Thank you so much, everybody, for your participation and your great questions.
Thanks so much, and we welcome your feedback. In fact, one reason we put on this session is because of the feedback we received from you. So let us know what you want to hear, and we'll be happy to put on another webinar. Thanks, and goodbye.
Thank you.